The broadcast is now starting. All attendees are in listen-only mode.
Good morning. Thanks for joining us today for our webinar. My name is Carmen Boone. I'm an education coordinator from Oregon Pacific Area Health Education Center, a hosted agency of Samaritan Lebanon Community Hospital. Our mission is to promote access to quality health care through community and educational partnerships. I'll be your host and moderator today. Let's go over some housekeeping items. On your GoToWebinar control panel, you will notice that all microphones are muted. They'll remain muted during this session. If you are experiencing audio difficulties, make sure your computer speaker volume is turned up or use the phone option to listen in. You may download today's slides from the handouts menu. Send us an email request if there is a problem. Use the questions menu for typing questions or comments at any time. This webinar is being recorded and will be available on our YouTube channel. If you have any questions, please email me at the address that you see on your screens. Now, let's talk about credit for participating in this webinar. To obtain CME or CE credit, contact hours, or a certificate of attendance, you must log into www.eeds.com and enter this activity code. Please write it down for your records and consider that the activity code expires in 1 week. We will email you these instructions today, about 2 hours after the webinar. This presentation is jointly provided by the National AHIC Organization, the American Cancer Society, Samaritan Health Services, and the Oregon Pacific Area Health Education Center. And the presenters and planners of this activity report that we have no conflicts of interest or relevant financial relationships with any commercial entities that might affect the contents of this presentation. This webinar is presented by Dr. Patrick Hagerty. He's a dentistry practitioner in Albany, Oregon, born and raised in Albany, and he has started practicing in 1986. He is affiliated with Samaritan Health Services, and he was part of the head and neck cancer reconstitution team at OHSU, while acting as the hospital site director for the general practice residency from 2015 to 2019. In his free time, Dr. Hagerty enjoys cooking, skiing, and fishing. Now, without further ado, I will leave you with Dr. Hagerty.
Thank you so much, Carmen. Welcome, everyone. Very important subject today. HPV-mediated oropharyngeal cancers is the framework by which we talk about this, specifically the dental version of You Are the Key. And we're going to talk about, over the course of the next 45 minutes to an hour, about that premise. You are the key. Quickly, you'll see how fast rates of oropharyngeal cancer are exploding, and I realize that's a medical term, exploding. Nationwide, unprecedented amounts of oropharyngeal cancer, specifically in men, and we'll talk about how and why, how your role as a practitioner, whether you're assistant hygienist, dentist, whatever your role is, you have a role in the prevention of this disease, and then initially we'll talk about recognition of this disease. We're going to talk about why HPV vaccination is important for cancer prevention. Yes, this is a dental issue. We're talking about oral cancer. There are other cancers that are prevented as well, but the door opens because of the oral cancer. We're going to talk about an oropharyngeal exam. I'm going to give examples of an HPV-mediated oropharyngeal squamous cell carcinoma, and we're going to walk you through the treatment. We're going to talk about an HPV vaccination schedule, what's appropriate, when and how to make a recommendation, how to practice self-efficacy in delivering these effective HPV vaccination recommendations. how to do it with a reassuring, confident, concise response to parental questions about HPV vaccination. We're also going to talk about vaccination delivery. However, this program is not meant to give any kind of CE or certification, for want of a better term, relative to the administration of vaccinations. The way it has been structured in the state of Oregon, dentists can now give all vaccinations to include the HPV vaccine. And we'll touch on that. We'll touch on the role that dentistry has in delivering that vaccine. Let's talk about what this is. What's the burden? What's the infection? What's the disease? So, first warning, in a few slides here, I'm going to show you an open tumor resection of an oropharyngeal cancer. I'm going to show you a photo of how it presents in the mouth. We're going to look at the CTs, and then we're actually going to have the surgery. If you're squeamish about a bloody field, this is something you may want to turn the monitor off. I'll give a second warning right before the 2 slides that show the surgery. The reason for showing this is very clear. Why would we go through all of that surgery, all of that morbidity, potential mortality, if all we needed to do was a vaccine? So as you look at these slides upcoming, think about your recommendations to that family of preteens, young teenagers. We need to talk about this HPV vaccine and prevent all of this from happening. So let's look at a case. So this is a gentleman with an oropharyngeal tumor in a very stereotypical presentation here. This is extended up into the soft palate. As we look at the nasopharyngoscopy here, so we've gone in the nose and we're looking straight south. Here's the trachea, epiglottis, base of tongue, and this is all tumor right here, all tumor. And indeed, tonsillar bed and base of tongue is where we see these HPV-mediated oropharyngeal squamous cell carcinomas. Here's the CT scan, the same case, and it is the same person all the way through on this. Obviously, of the head, you see the mandible here. This is the right-hand side, and you see this gray area right here. Compare it to the left, where we can see anatomy distinctly. This amorphous blob, if you will. The next one, we go a little bit further south, and we can start to pick up lymph nodes that now have active disease in them. Second warning, the next slide is that open resection case. And again, as we look at this case, why don't we just prevent the whole thing from happening to begin with? Here it is. So, same gentleman, obviously upper jaw, nose. Right here is the nasotracheal tube. So this is a tube connected to the anesthesia machine, the ventilator, and that's going through the nose. And here you can see it peeking out, going further south into the trachea. The mandible has been bisected right here, cut clear through, and the right proximal portion has been rotated out of the way. So there is the premolar right there that used to be right next to this canine to orient you. Here's the inferior border of the mandible that used to line up right here. Base of tongue, you can see all the dissection. The black areas are from cautery to control bleeding. If one were to look at an x-ray of this post-op, there'd be multiple titanium staples used to close off arterioles. Why don't we just prevent this from happening to begin with? A vaccination, that's all we need to do. One more slide showing the surgery. Here that mandible has been rotated back and plated into place. There's that premolar that was up in the mucosa. Mental foramen with the mental nerve feeding on out into the mucosa here. And then what's remaining is the approximation of the soft tissue and closure of the remaining soft tissue. Why don't we just prevent this? What are we talking about? HPV, there are different types and different disease associations with those types. Something like 150 different types of HPV are recognized. Over 40 are of a mucosal type, over 80 cutaneous type. And these are the virus that causes the common hand and foot warts. What we're talking about today is the mucosal sites of infection, and it branches off. High risk, which is the oncogenic cancer-causing types of virus. The most common are HPV 16 and 18. There are others, but the bulk of the tumor oncogenic activity is HPV 16 and 18. Here we're talking about cervical cancers, anogenital, oropharyngeal, cancer precursors, and low-grade cervical disease that, left untreated, ultimately would be cervical cancer. The other types of mucosal HPV causes the genital warts, laryngeal papillomas, and low-grade cervical disease as well, often not going on to, or I should say most often not going on to outright cancer. Our vaccinations cover both oncogenic, the most common, and the most common non-oncogenic mucosal infections. Most HPV infections happen during the teen and college-aged years. This is associated with the sexual debut of people. Most people never know that they've been infected. Women may find out that they are infected because of an abnormal Pap test with a positive HPV test or a diagnosis of genital warts. Men may find out because of genital warts as well. A lot of information in this slide. Let it soak here for a moment. The top bar and the bottom bar really demonstrate what we're talking about today. Cervical disease, cervical cancer, you can look at our numbers here, and I believe this is from 2016 is the data for this portion of the graph. Compare that cervical cancer to oropharyngeal cancer in men. It's a bigger number. And since 2016, this disparity has continued. There are far more oropharyngeal cancers in men than there are cervical cancers in women. Oropharyngeal cancer is not unknown in women, but it is not the impact that HPV cancers are with the cervix and the oropharynx. Another angle to look at disparities between men, women, race, and ethnicity. This left-hand side here, all races combined, women versus men, and again, this is only looking at oropharyngeal cancer. This is one where one could say the men are winning the race on this one. Not a very pleasant contest, however. With women, there are 196,000 high-grade cervical lesions every year. This demonstrates what's known as a cone biopsy because of the shape of the tissue that is removed from the cervix. This has come about as a result of an abnormal Pap smear. In the United States, certainly around the Western world, there is an entire system in place to catch this in women. One could even call it the annual guilt trip. You got to go in. You got to go in and get your Pap and pelvic. Nothing exists for oropharyngeal. And as that bottom line says, cancer, the oropharyngeal cancer incidences have exploded. We are seeing so many more. Going back to that original slide, when we started the conversation, that case was one of Dr. Dan Petrosaur's, who works out of OHSU. I worked with him in the head and neck cancer reconstruction team and giving these people their smile back. You will see those tumors in your office. There's an entire cohort, we'll talk about more in detail later on, but I want to plant the seed now. There's an entire cohort of people who have not gotten the HPV vaccine, who mistakenly believe that they're too old to get it. These tumors will be seen in dental offices. When you see something like that first slide, that ulcerated area, the red margins, the erythematous raised margins, it's important to have a system in place. What do you do with those? First of all, you need to talk to your staff. The hygienist, the assistant, when the eyebrow goes up that this is something serious, who are you going to refer that person to? Have that conversation ahead of time before you see one of these tumors come in. Do you make the referral to your OMS, oral maxillofacial surgeon? That is the most common route out of dentistry, but it's your local OMS set up for medical insurance billing. Some are not. I know in dentistry, sometimes we complain about the pitfalls of dental insurance. It's nothing compared to what medical insurance billing is like. In my office, we do quite a bit of hospital dentistry. We're in the operating room 2 days a week. We also bill for sleep apnea appliances, and it is an animal unto itself. Have that conversation ahead of time. Are you going to use the OMS directly? And then they make a referral on to someone like Dr. Petrosor at OHSU, or do you refer it to your local ENT? Doesn't matter as long as the patient's getting care, getting a biopsy, and that there is a fluid line, that it happens without thinking about it. There's nothing worse than having to get on the phone and invent the wheel as to how these patients are managed, because you will see it. I remember one of my attendings when I was in residency in the mid-'80s was giving a seminar, and one of the people in the seminar said, well, I've never seen one of these in my office. And my attending, because he's an academic, could get away with it and said, well, it's because you're not looking. They're there. Statistically, we know they're there. And this is back in the days before HPV. This is the standard drinking, smoking, oropharyngeal tumor in the anterior mouth. Now with HPV, the incidence is so much greater. Have the conversation ahead of time, the routine established ahead of time with your staff and whoever you're going to refer to for that biopsy. The HPV vaccine is cancer prevention. That's how we need to think of it. It's cancer prevention. When this was first rolled out, it was rolled out for girls only because of cervical disease, and it was couched as to prevent a sexually transmitted infection from going on to cause cancer. Vaccine rates bombed. It was poorly done, and everyone involved did a mea culpa and said, okay, we screwed this up. Let's step back. Let's look at how we can get this across to families, parents, moms who are making most of the healthcare decisions in a family. How can we roll this out so that they understand this is cancer prevention? So as you talk about this with your patients, you may hear about that old rollout of sexually transmitted infection, cancer prevention. Be mindful of it and say, yeah, they kind of goofed that one, didn't they? And go immediately to cancer prevention. What does it look like? What is the HPV vaccine? It's what is known as a virus-like particle, VLP. It's non-infectious, it's non-oncogenic, but it fools the system into thinking that it is indeed virus so that an immune response is built. Because of how this is administered and how the VLP is delivered, the body actually produces a higher level of antibody than a natural infection. It is a very robust response. What are the different vaccines that are available? I think it's important to talk about some of the older ones, the bivalent and the quadrivalent, not available anymore. They're not to be used, but people have been vaccinated with them. The original ones were for 16 and 18, which, as we've discussed, are the the two major cancer-causing viruses. Then the quadrivalent came out to cover genital warts, the non-oncogenic. And then the 9-valent came out to bring in 4 more of the oncogenic virus varieties to give further coverage. The question comes, what if I've been vaccinated, say, years back with the bivalent, and sexual practices have changed, a new partner, a divorce, a death, something along those lines? Maybe we need to consider the new vaccination, the 9-valent. This is the one that's available. You can see the strains that it covers. It was in the previous slide as well, I realize. And as I said, the others are obsolete, and this is the only one to use. When do we use it? The recommendation is age 11 to 12, and there are a number of reasons. One, only 2 doses are needed. And with those 2 doses, the immune response in this age group is so robust that it is greater than someone getting 3 doses later on in life. There's something about that preteen immune system that rallies a big response to give very good immunity. We start talking about it early. HPV vaccination is going to be coming up. It's important to prevent these cancers because they show up. About 4 years ago, maybe 6 years ago, I had 4 of these HPV tumors, oropharyngeal tumors, cancer in my practice in one summer. 4 of them. They are there, they will be coming, and you can talk about it in a very knowledgeable way, that this is not something that you ever want to even think about, let alone the other genital tumors that can come about as a result of an HPV infection. If it's a little bit later in age, still 2 doses. If you start before age 15, it's 2 doses. Another reason for this age group, mom and dad's IQ is still pretty healthy. As parents, we're not getting dumb yet in the eyes of our teenager as we progress along here. A lot more control over schedules. You know where they are. You know that there are other vaccines to be given. You do them all at the same time. We can start as young as 9. And again, this is girls and boys. There will still be people out there who remember the rollout of this is that this is a vaccination for girls. It's girls and boys for all the reasons we've talked about. Different tumors, cervical obviously in women, but the oropharyngeal in men, as well as some of the other genital tumors. First dose is given. The 9-valent, the only one we're using. 1 to 2 months later, a second dose, and then 6 months after the first, the third dose, if indeed that's what's needed. Right now, the vaccine is recommended for everyone through the age of 26. However, it has been approved for 27 to 45 years of age. And again, this may be a lifestyle change, not adequate vaccination earlier or none. It doesn't have quite the benefit because the patient may have already been exposed to HPV, but were they exposed to one of the oncogenic HPVs? You don't know. People would have a cost-benefit discussion about this. Personally, I would say that if you can prevent any of these tumors, the cost is pretty low to get the vaccination. Dosing schedules. Start the vaccine series before the 15th birthday. It's 2 doses. Second dose should be administered 6 to 12 months after the first dose, with a minimum interval of 5 months. We need to allow that immune system to do what it's going to do in that 5 months, and then we bump it again with the second injection. If we start the vaccine series on or after the 15th birthday, then it's 3 doses. Second dose, 1 to 2 months after the first, and the third dose, 6 months after the first. We need a minimum span of time for that immune system to give the biggest and most complete response. The way it's given, it is an IM injection, inch to inch and a half, 22 to 25 gauge, needle in the deltoid muscle in the upper arm. Right now in the state of Oregon, for dentists to give vaccinations, there is some CE required. It's kind of a 2-step process. And this was learned from the experience with pharmacists. There were a number of shoulder injuries when the pharmacist started giving the injection because it was being given too high, not down in the belly of the deltoid muscle. And it was because of that experience that the Oregon Health Authority said, we need to have some more specific CE for the dentists. We didn't do it with the pharmacists. It was a mistake. Let's prevent these problems. For those of us with hospital affiliation and training, this is something we've done all along. But for the majority of dentists, you're not doing IM injections. Straightforward CE, not a bad idea to get it. Aseptic technique, of course, and hard to believe we actually have to put in there that use a new needle and syringe for each injection. Of course, that's given. And if possible, you want to give that vaccination at the same time as others. We'll cover that a little bit more. Storage, 36 to 46 degrees in a monitored medical refrigerator. Original packaging, do not freeze the vaccine. Let's talk about the safety of the HPV vaccine, how it's monitored, and for that matter, all vaccinations. There are 4 national groups, federal groups, with different collaborators. You can see the CDC's involved in the first 3. The bottom one, the FDA and partner organizations are involved with what's called PRISM. After licensure of a vaccination, they're monitored. We're talking about over 53% of the United States population is the database. When issues come up and they start seeing a trend, they then can act. You probably have read about the recent issues with the Johnson & Johnson vaccine and the potential for clotting. It's this system that's picking that kind of thing up. You say, wait a minute, let's really crunch this data. Is there really a problem here? Do we need to change how we're administering or stop it completely? And as you know, the Johnson & Johnson has a hold on it right now until they figure out indeed what is going on. We got a lot of years of safety data. They are safe. Like any injection, vaccination rather, pain, redness, swelling in the arm where the shot was given. Sometimes you get a fever, headache, and again, that's part of the immune response. If there is an allergy to yeast, the HPV vaccine shouldn't be used. And like any other injection, whether it's a vaccination or not, syncope and related symptoms such as the jerking movements that you can have as a result of someone passing out. Not a bad idea to have somebody stick around for 15 minutes. That's the standard anymore. And absolutely, they should be seated. One can relax that arm much easier and have the least amount of side effects from that injection. The safety profile for the HPV vaccine is outstanding. CDC and FDA continue to monitor it. Mentioned those 4 groups in the previous slides that continue to watch all vaccines to include the HPV. You can tell parents that this thing is safe. And again, go back to those first slides of that surgical case. It's that or a vaccine. I vote vaccine. How do we monitor this? What happens as a result? Early outcomes We see a drop in HPV prevalence and in genital warts. We'll get into some details about this aspect of it. Cervical intraepithelial neoplasia, precancers, years to decades after the inoculation, and then down the road, decades, HPV-associated cancers. These cancers can literally take decades. The oropharyngeal type especially, 20, 30 years after the initial exposure before the tumor is diagnosed. Cervical precancers, genital warts have all dropped as a result of the HPV vaccine in the United States. If we look at this slide, in age groups, 18 to 20, 21 to 24, over this time span to 2015, that's the kind of graph you want to see. What a downward slope. Big impact on precancer lesions. This out of Australia speaks to herd immunity. This is 2004 to 2011. The reason this is included in today's presentation is that this is in the time frame where the vaccination was given only to girls, not to boys. With females, you can see the drop in genital warts. Again, you want to see this kind of graph. Well, this took a big reservoir of HPV, genital wart HPV, out of the population, and in the boys' population, look at this, it drops also. This is a very good demonstration of herd immunity. There are enough people vaccinated that it dropped the presence of the genital wart HPV in the population that then affected other people who were not immunized, but because the vaccine of the other group, the other cohort, the boys did not see the occurrence of genital warts in the same level they did when things started in 2007. Pretty amazing. What's the duration? Right now, the evidence is that it's at least 10 years. There are multiple studies that are following this, whether or not a booster is needed. Titers can be done down the road to see, are you still immunized with this, especially, again, if there's a change in sexual partners, a change in social life, that might be an indication. But right now, it looks like it's very long lasting and a booster is not needed. Benefits far outweigh any potential risks. Benefits far outweigh any potential risks. You can repeat that to every single patient you see. In terms of safety, it's similar to the meningococcal and the Tdap vaccine, the tetanus, diphtheria, pertussis vaccine. And to group it together with other vaccinations and be able to state with knowledge, with confidence, that indeed this is a vaccine that is in the same category as all these others that are already being given to your child. We add this one vaccination to prevent cancer. How do we talk about it? How do we frame the conversation? Adolescent vaccination coverage, you can see the Tdap and meningococcal vaccines, and then look down here at HPV. Why the discrepancy? What is going on here that as a percentage we're so far down? Again, it's how you couch the conversation, how you have that conversation. Another variable here is rural areas. It's true for HPV vaccination, but it's also true for all vaccinations, that there is a good 12% lower vaccination rate in rural areas. We could probably have a seminar on that one issue alone, but we can just say simply that maybe things aren't recommended on as a consistent level in the rural clinics as they are in more urban areas. And here you are. Fewer patients in rural areas report a recommendation for an HPV vaccine from their provider. That's a big number difference, 7%. We need to be recommending this vaccination. Vaccination coverage is higher among those reporting a recommendation. This is consistent with any and every vaccine that has ever been made. When there's a recommendation, it happens. For the 78% that did get a recommendation, as opposed to the 22% who didn't, vaccinated went on to be 75%, 25% not vaccinated. For those that did not get a recommendation, look at the difference. Huge disparity. We can change this. We are part of that healthcare team to be talking about vaccinations and their importance. We can drive it right into oropharyngeal cancer. Why, you dentist, hygienist, assistant, why are you talking about a vaccine? You do teeth. Well, yeah, we do. We also do mouth. We also recognize oropharyngeal cancers. People are in the dental office far more often than they are in a primary care office. We can see these things, we can catch these things, and really explore our role more completely as part of the healthcare team. Vaccinations are one component of that. Parents of unvaccinated adolescents, top reason for not starting the HPV series, 10%, it was not recommended. That is a big number. The not sexually active, I've had that question. No, but they're gonna be, I hope. It's biology, it's part of life, part of being a human, and you're not gonna be able to screen their partners, but you can protect them with this vaccination. As clinicians, we underestimate the value of our recommendations. And specifically with HPV, we talk about the meningitis, hepatitis, pertussis, influenza, drops off a little bit here. And then here's HPV. Parents put it very high, that it's very important that we make a recommendation. They value it. They appreciate it. For some reason, we as clinicians, whatever. I believe that it's part of that original rollout that this is for an STI. And that's all it is. No, this is cancer prevention. This vaccine is about cancer prevention. A difference between perception and reality. Perceived concerns versus real concerns. Parents want to hear this. Give an effective recommendation. HPV vaccination was much higher when parents reported receiving a recommendation. Moms trust their child's clinician. You're part of that team. You are one of that child's clinicians. Moms is mentioned here because study after study shows that the mother and the family is most responsible for healthcare decisions. What is an effective recommendation for an HPV vaccination? What's it look like? The most straightforward, effective way is to recommend it the same way you do any other vaccination, and you give it the same day. Give the recommendation the same way, give the vaccinations the same day. If possible, to give that vaccination that same day. List off the vaccines: meningitis, HPV cancers, and pertussis. We need all of these today. It's part of the list. And again, HPV cancers, not STI cancers. This is cancer prevention. It's a bundled recommendation all at once. Same way, same day. Sophia's 11. She's due for 3 vaccines. This will protect her from meningitis, cancers, pertussis will give those shots today. Let's talk for a moment about HB 2220, which allows dentists to administer vaccines in the state of Oregon. I had the privilege of representing the Oregon Dental Association and testifying before the House Healthcare Committee about dentists administering vaccines. Those of us in dentistry know that this is well within the wheelhouse in terms of our background of training, our understanding of physiology and pathology. It's just the mechanics of giving an injection. Folks with little to no education are giving these injections, let alone a dentist that many of us have our advanced cardiac life support training, to deal with any kind of a very, very rare anaphylactic response. It is well within our wheelhouse. The decision for a clinic about giving vaccines is a complicated one. Do you want to deal with the medical billing, the storage, the setup? Do you want to have a relationship with a pediatric clinic, primary care clinic, to be able to get folks right over there, say, Johnny's in, he's 11 and a half, regular checkup, have you done these vaccines? Boy, we need to do that. Can we call your PCB and set up that appointment right now? Let's do that. Have a connection to get those vaccines delivered. If you choose in your clinic to do them yourself, wow, wonderful. Or if not, then how are you getting them done? How are you getting them into their primary care clinic? Have a system in place. Well, why should we do it? It prevents cancer. Period. Stop talking. It prevents cancer. And in boys, you can talk about the explosion of oropharyngeal if you want to go further. But I think it's simple enough simply to say this prevents cancer. Simple answers: cancer of the genitals and the throat. And then stop talking. Does my kid really have a risk here? Yeah. Very common virus. Affects males and females. And again, this comes back to that original rollout that it was for girls only. And so there are some folks where we've got to make that change in their mind that boys are in this as well. And I realize we've already talked about the tumors that affect men, because this takes decades to express itself as a cancer. Common virus, and it prevents the cancers, diseases caused by this virus. We'll start the HPV vaccination today. We'll set up that appointment with your primary care clinic right now. We've touched on this, 11, 12 years old, and it's kind of a silly slide that demonstrates the idea, but going back to a previous slide, this age group, 11 to 12, mom and dad's IQ is still pretty reasonable. We're not getting done yet. We have more control over their schedule. And we get the biggest immune response in this age group with 2 shots, and even bigger response than someone later in life after the age of 15 getting 3 shots. So there's a lot of benefits to it. When does the bike helmet go on? Before they get on their bike. What do you tell parents who think their kids don't need the HPV vaccine? How do we approach that?
For me, this is the moment where I actually start asking questions. And so you sort of pause for a moment and you ask the parent, so tell me more about that. So I'm hearing you saying that you don't want to give the vaccine. Is there something in particular that is making you think he doesn't need it? Or, why do you think your child doesn't need it? And let them explain sort of more about where they're coming from and what their position is. And then it really helps me to answer their questions or to figure out where I might be able to help redirect them to understand a little bit differently where I'm coming from. The most common one I've heard is, my kid's not sexually active yet, or they're not thinking about sex. And my answer to that is, oh my gosh, it's fantastic. They sort of look at me a little bit strange because they're like, why are you excited about that? And you're like, well, I'm excited about it because vaccines are something that you want to give before something happens. And so the fact that they haven't started having sex is perfect because it means that we have time to get in both doses of the HPV vaccine before they're ever exposed, which means it's that much more likely that it's going to protect them against cancer. And for most parents, that's enough to sort of flip the switch a little bit and change their mind.
Drives it home pretty well. I think one of the things to remember when you have this discussion and you have somebody who is putting the hand up and said, no, I don't want to do this, you don't want to turn them into an enemy. You don't want to lose that patient to ongoing care. You know, if someone has got their heels dug in and is an anti-vaxxer, you're likely not going to change their mind in that discussion chair side. You can give information, but we don't want to make an enemy out of them. We don't want to lose that child to recall. We don't want to lose dental care that is in place and is ongoing because of a conversation about vaccines. It's important to talk about the vaccines, but if someone absolutely has their hand up and said, no, maybe it's time to back off. Hey, we're here. We have information for you. We can talk about it to any length that you want. I certainly do recommend it. Both of my children have been vaccinated, and you drop it. And you can say, yes, I hope it's true. All the people involved in healthcare in the United States support HPV vaccination. Very, very real results in cancer prevention. Children, I could say especially, are in a dental chair more often than they are with a primary care provider. And we can talk about oropharyngeal cancer facts. We can talk about HPV. We can talk about preventing this disease from beginning. Dentistry, we're uniquely qualified looking at the mouth and understanding the ramifications of a tumor becoming established and then what's involved in cleaning that tumor up. I take you back to those first slides of that surgical case. Do you really want that for your patients? Public health really wants the dental community involved in this. And again, because we're seeing people far more often than primary care providers. This is quite a statistic. I was actually surprised by this. 84%, over 84% of children in the United States had an annual preventative dental exam in 2016. That's a huge number. And that's an interface with that family, with the parents, with the mom, to talk about HPV. This, I realize, is redundant, but it drives it home. A vaccination as opposed to this mess. So involved. The morbidity is just not fun. Radiation, when it's involved, people often have to have a feeding tube placed because they can't swallow because it's too painful. A lot of narcotics involved with during this treatment. Let's just prevent the whole thing. Let's just not do it to begin with. I think one of the pearls of this program today might be the biggest pearl after understanding the role of HPV vaccination and prevention of cancer is to have the conversation with your staff ahead of time about the importance of HPV vaccination, having everyone on the same page. While I was at OHSU, a primary care clinic noticed that vaccinations were accumulating in the refrigerators in the back and actually crowding up to expiration. And they said, well, wait a minute, we're not using as many. Well, why not? And they started looking at it, and vaccination rates had plummeted in this clinic. Turns out, someone at the front desk was an anti-vaxxer and was making sure that every parent heard about it. Vaccination rates plummeted as a result. Personnel changes were made. Vaccination rates came back up. You want everybody on the same page. Condition of employment, however you want to do it. If you're an anti-vaxxer, that's fine, but you have to keep it to yourself. Or you're in a place in the office where you don't have that patient interaction that would dissuade someone from this scientifically proven, well-established prevention of disease. CDC has brochures, talking points, how to broach the subject, communicate the ideas. The key thing is engage your team, have everyone on board, able to talk about it knowledgeably and understand why it's so important. Again, the CDC has got brochures, material, resources for you to be able to talk to patients and give them more information. Have I beat this enough? All staff on the same page. Putting the focus on cancer prevention. Keep everyone up to date. Have a regular staff meeting. It doesn't have to be weekly. It could be quarterly. It could be twice a year. But just to be sure that everyone is still talking about it and is aware of the current recommendations. HPV vaccine is cancer prevention. Cancer prevention. And you are the key. Thank you so much for your time today. Here are references that were used in today's presentation. I hope you enjoy the rest of your day. Thank you so much.
Thank you. So some items to keep in mind while you write your comments and questions. Remember, we'll try to answer your questions, all of them. If we don't run out of time, we'll answer them via email. Please claim your certificate to complete the program evaluation. It'll take just a moment and it'll be of great help to us. Remember, the activity code expires in 1 week. We'll repeat it in a second. The webinar is being recorded and will be available on our YouTube channel. Feel free to reach out to me or our office if you have any questions or concerns. We'll be happy to be of assistance. And today, in about 2 hours after this webinar, we will email you the instructions on how to get your certificate and how to watch our recorded videos via our YouTube channel. This is the activity code. Please write it down for your records. And let's see if we have questions or we have a comment. Says this was really great. Thank you. Remember to download your handouts. They are under the drop-down menu named handouts. There you'll be able to find 4 different handouts. We're hearing back from Laura and Cheryl. Thanks for participating with us today. And since we are not receiving questions, remember that you can email us if you get any questions later. And we'll be happy to get you the answers. And thanks for being with us today. Thanks to our speaker for sharing his time and knowledge with us. Thanks to all of you for participating today. You have now completed the session and you may disconnect. Have a great day.